This talk is about mental status evaluation. Mental status testing is unlike any other component of the neurological exam. The routine neurological exam is usually conducted after taking the history and conducting a general examination. Most neurologists I know start the formal neurological examination by testing cranial nerves, which usually take a large chunk of the time allotted for neurological exam. Then they go to the motor exam, which is also quite lengthy. Then to the sensory and cerebellar exams, which usually takes less time, and then go to the mental status exam, which is usually quite brief. Yet the reality is that since mental status evaluation relies heavily on observation, the mental status exam is conducted throughout the course of the neurological examination. And even from before, we could say that neurologists start mental status evaluation from the time they say hello to the patient. As all other components of the neurological examination, the mental status exam is conducted for the purpose of detecting and localizing neurological deficits. So a fundamental question is, what structures are being evaluated during mental status exam? Mental status examination tests certain areas of the cerebral cortex and some subcortical structures. We will first mention the areas of the cerebral cortex evaluated during mental status exam. The cerebral cortex consists of a 2.5 by 2.5 feet mantle covering the surface of the brain. The cerebral cortex is constituted by the primary cortex, the unimoral association cortex, and the multimodal association cortex. The primary cortex is not examined during mental status examination, but its normal functioning is required to conduct a full mental status exam. Examining the unimoral association cortex is also not the thrust of the mental status examination, but some portions of the unimoral association cortex is tested during the mental exam, and more importantly, as with the primary cortex, the normal functioning of the unimoral association cortex is required to conduct a full mental status exam. The multimodal association cortex, on the other hand, is the primary target of mental status evaluation. In addition to the cerebral cortex, during mental status examination, we evaluate subcortical structures, mainly 5. The ascending reticular activating system, the anterior and medial dorsal nuclei of the thalamus, the hippocampus, the amygdala, and the mammillary bodies. How is mental status evaluated? Mental status examination tests consciousness. Consciousness has two components: arousal and content of consciousness. They are both tested. The evaluation of arousal is usually done while taking the general history and summarized right at the beginning of the general examination report by stating that the patient is alert. The questions asked to arrive to a conclusion about arousal are related to the effort needed to achieve arousal, whether voice, touch, or pain suffices to produce arousal. The anatomical areas being tested during the evaluation of arousal are the cerebral cortex, unimoral and multimodal association areas, and the ascending reticular activating system and related structures. After arousal, we check content of consciousness. I like to divide the evaluation of content of consciousness in three parts: speech, the acronym JAMIO, and NGP. N stands for neglect, G for nausea. Nausea means the faculty of perceiving and recognizing. And P stands for praxia. Praxia being the ability of performing previously learned skill motor acts. Let's start with speech. Speech is evaluated by three routes. The first route is by asking simple questions such as, is there any speech problem, any hearing problem, and any brain surgeries? The second route is by noticing during the history taking several characteristics of language, such as fluency, crispness, understanding, prosody, that is the affective component of language. A prosody or motor aprosody implies the production of a speech without affective connotation. This type of a speech indicates non-dominant hemisphere pathology in the area corresponding to the dominant hemisphere Broca's area. Sensory aprosody implies the inability to comprehend the emotion content of a speech. Sensory aprosody indicates a lesion in the non-dominant hemisphere in the area corresponding to the dominant hemisphere Wernicke's area. We also need to notice naming difficulties, wrong words, and made-up words. The third route, we evaluate the speeches by requesting the patient to repeat, to do some type of action like looking at a window, or asking them to show us the right thumb, asking the patient to name objects, to read, to follow written instructions, copy a sentence, and to write a sentence of the patient choosing. After evaluating speech, we move to JAMIO. This is an acronym used to help us remember some of the areas we need to test during mental status evaluation. In this acronym, the letter J stands for judgment. The A can stand for appearance, but often appearance is consolidated as a part of judgment. The A can also be used for affect, but as with appearance, affect can be rolled into judgment. Hence, we will use the A for attention, M for memory, I for intelligence, and O for orientation. So let's start with judgment. Judgment refers to the ability to make a cohesive and reasonable interpretation of events, real or imagined, and to display the right behavior for the circumstances. Judgment is tested by observing behavior, asking questions about life, and proverb interpretation, such as asking the patient why it is said that a man living in a glass house should not toss stones. Judgment should be judged taking into consideration the patient's cultural bias and our own. Bad judgment can take many forms. Different types of bad judgment suggest pathology in different parts of the brain. If you see or elicit a history of apathy, poor logical thinking, lack of motivation, abnormal appearance, or lack of drive, you should think of localized pathology at 3 locations: 2 in the cerebral cortex and 1 at the subcortical level. In the cerebral cortex, pathology can be localized, as we just mentioned, at 2 sites. The most likely site is a region of the anterior multimodal association cortex, indicated by the arrow, called the frontal dorsolateral association area. This area is heavily interconnected with the multimodal association limbic and posterior cortices and with unimodal association cortices in the lateral surface as represented here, but also with those in the mesial surface of the ipsilateral hemisphere and with the contralateral frontal dorsolateral association area. The second cortical area where damage can lead to the findings previously described is also in the anterior multimodal association cortex, but in the mesial surface of the brain, in an area called the ventromedial association area. This area has very strong connections with the amygdala and the entorhinal cortex. The ventromedial association area also connects with the mesial limbic cortex, hypothalamus, and with the brainstem. In addition to the 2 cerebral cortical regions just mentioned, these findings can also result from a lesion in 1 subcortical structure, the mediodorsal nucleus of the thalamus. The mediodorsal nucleus of the thalamus sends a large contingent of fibers to the anterior multimodal association cortex, mostly to the frontal dorsolateral association area as shown in this frame. Bad judgment can also be expressed as inappropriate behavior, antisocial behavior, disinhibition, lack of empathy, inability to understand jokes, inappropriate jocularity, and mood swings. In the presence of such findings, you should consider pathology at 2 cerebral cortical locations and 1 subcortical location. The 2 cortical sites are, first, the area of the multimodal anterior association cortex indicated by the arrow in this frame, called the orbitofrontal association area. This area is heavily interconnected with the amygdala and with the anterior most temporal lobe region, which is a part of the multimodal limbic association cortex. The orbitofrontal association area is also connected with the hypothalamus and with the brainstem. One clinical relevant point about the orbitofrontal association area is that it harbors the olfactory multimodal association cortex, which, as you know, is strongly connected with the primary olfactory and unimodal olfactory association cortexes in the temporal lobe. Hence, patients with orbitofrontal association area pathology often display olfactory symptoms. The second cerebral cortical area often involved in patients displaying these types of behavior is the limbic multimodal association cortex in the anterior temporal lobe, which, as we previously mentioned, is interconnected with the orbitofrontal association area. The anterior temporal lobe is also interconnected with the amygdala. In addition to cerebral cortical pathology, the behavior just mentioned can occur in patients with subcortical pathology, when the subcortical structure involved is the amygdala. After judgment, we evaluate attention. The symptoms that suggest an attention problem are short attention, too much attention, and inability to focus. Attention can be tested in many different ways. My favorite is to ask the patient to tap with the index finger every time they hear me say the letter R. And I go on mentioning random letters intermixed with the letter R for about 15 seconds. At the conclusion, I tabulate the times the patient missed tapping when I said R. Normally, there is no miss. I usually follow this exercise by giving the patient a paper with typed letters, as shown in this frame, and ask the patient to find all the R's in about 20 seconds. Using relatively large letters, as shown here, none should be missed. These tests are good because they are simple. They do not require calculations nor much speech. The anatomical area being tested includes some cerebral cortical areas. Attention is primarily a function of the anterior multimodal association cortex, also called the prefrontal cortex. In the multimodal association cortex, the frontal dorsolateral association area is especially important for attention. In addition to the cerebral cortex, the ascending reticular activating system and the amygdala seem to contribute to attention, the latter by injecting emotions to the attention equation. After attention, the next area to consider is memory. Memory is a function of the cerebral cortex and subcortical structures. The cerebral cortical areas most involved in memory is the anterior multimodal association cortex, here shown, and among the different areas of the anterior multimodal association cortex, the frontal dorsolateral association area seems to be especially important. The frontal dorsolateral association area is considered by many the meta-memory center because this area has the executive control over the memory apparatus, arranging memory according to time, deciding what and when memory will be retrieved, and knowing where each memory is stored in order to retrieve it. In addition to the cerebral cortex, memory is also a function, as previously mentioned, of subcortical structures, such as the anterior nucleus of the thalamus, hippocampus, and mammillary bodies. These latter three subcortical structures are components of the Papez circuit. The amygdala also plays a role in the storage of emotional memories. Other subcortical structures not shown here play a role in different types of memories. I will mention them as we discuss the different aspects of memory. What symptoms suggest memory problem? Forgetfulness. How is memory tested? Memory is tested by checking immediate recall, the ability to make new memories, semantic memory, episodic memory, priming memory, and procedural memory. Instant recall or immediate recall is evaluated by asking the patient to repeat a set of numbers. Normally 7 numbers should be repeated with ease. Another way to test instant recall is by asking the patient to repeat 3 words, such as apple, book, and chair. The anatomical area being tested during instant recall is the perisylvian cortex, the same area that is checked during a speech when testing repetition. Conditions producing failure of immediate recall consist of focal lesions in the perisylvian region, such as stroke and tumors. The ability to make new memories is checked by asking the patient to remember the 3 words we ask them to recall at the beginning of the interview and asking the patient to repeat them at the end of the exam. Normally, they would be repeated in sequence. You can also ask what the patient had for breakfast or lunch, but that needs corroboration. At times, no question is needed. Your secretary will tell you that memory is a problem. The anatomical area being tested is mainly the hippocampus. Many conditions course with inability to make new memories. Among them are transient global amnesia and bilateral resection of the entire piriform amygdaloid hippocampal complex. This MRI, as you can see, shows the absence of the piriform amygdaloid and hippocampal complex. They were resected in this patient to control seizures. You can see the missing structures here indicated by the arrow and also on the other side. After surgery, the patient's ability to make new memories was lost. Semantic memory is checked by asking facts, such as what is the capital of France. The area of the brain tested are the prefrontal cortex, especially the frontal dorsolateral association area, the anterior region of the temporal lobe, and the inferior temporal gyrus, which can also be seen in the inferior surface of the brain, bound medially by the fusiform gyrus, also known as the temporal-occipital gyrus. Semantic memory loss is often seen in Alzheimer's disease and frontotemporal dementia. Episodic memory is checked by asking personal questions about autobiographical events. Recent autobiographical memories are more vulnerable than remote autobiographical memories to be pathologically forgotten. Hence, pathologically forgetfulness affects recent memory first. The anatomical areas involved in recent memory includes the prefrontal cortex, especially the frontal dorsolateral association area, the hippocampus, the posterior multimodal association cortex, which occupies large portion of the parietal lobe, and the temporal lobe in the lateral surface of the brain, and the limbic multimodal association cortex, also present in the lateral surface of the brain and in the mesial surface of the brain. Conditions that produce episodic memory loss include transient global amnesia, hippocampal strokes, chronic exposure to toxins, Wernicke-Korsakoff syndrome, often seen in alcoholics due to B1 deficiency, herpetic encephalitis, and Alzheimer's disease. Priming memory is checked by asking the patient to complete a partially drawn figure as indicated in this frame, or by asking the patient to complete the missing letters in a word. The anatomical areas involved while testing priming memory are widely spread in the cerebral cortex, that is, in the primary unimodal association and multimodal association cortex, depending on the task given for completion. Procedural memory is checked by asking the patient if they have lost the ability to do something he or she used to do, such as playing the guitar, riding a bike, or typing. The brain areas tested include the striatum, the substantia nigra, the cerebellum, and the premotor and supplementary motor areas. Conditions that produce procedural memory loss include Parkinson's disease reflecting substantia nigra involvement, Huntington disease reflecting involvement of the striatum. This is a sketch comparing a normal brain on the right and a Huntington brain side by side. Notice the diminution in the cortical mantle, maximally in the temporal region in the brain with Huntington's disease, and the shrinking of the lentiform nucleus. Another condition that can produce loss of procedural memory is cerebellar degeneration. Notice how small the cerebellar folia are in the three views. After memory, we test intelligence. Intuitively, we all know what it is to be intelligent, although definition and testing, especially during neurological examination, is difficult. Defining intelligence as something that helps us plan, reason, solve problems, quickly learn, think on our feet, make decisions, and ultimately survive in the fast modern world, we can surmise that the finding that suggests the lack of intelligence is a failure in the above mentioned areas: lack of foresight, lack of abstract thinking, and lack of tact, qualities needed for success. Intelligence is tested during mental status examination by proper interpretation, just as we do to test judgment, by obtaining information about being street and business smart, and by the patient's achievements in their chosen area of work. Deterioration of intelligence is often present in these areas before they can be detected by formal testing. I also, during intelligence testing, ask the patient to do calculations. The area of the brain tested include the cerebral cortex, especially the multimodal association cortex, and very especially the anterior multimodal association cortex, but also cortical neuron connections, which can be gauged according to some authorities by the size of the corpus callosum. Conditions associated with lack of intelligence are genetic, that affect cortical neurons differentiation, migration, and interconnections, and dementing disorders that injure cortical neurons and their connectivity. After intelligence, we test orientation. Orientation is tested by asking about time, what day it is, place, where are you now, and person, what is your name. Orientation is usually tested indirectly during the course of the interview. Asking for the patient's name at the end of the interview does not sound too good. The anatomical areas being tested are in the cerebral cortex, especially the precuneus gyrus, the inferior parietal lobuli, and the medial prefrontal cortex. The next frame I will show you is not intended for you to spend time understanding it. It is just to show you one method used to adjudicating cortical function localization. In this case, about orientation. The study was done using high-resolution 7 Tesla functional MRI. Please pause the video for a few seconds and look at the pretty color pictures while you read the legend. So we have finished with the acronym JAMIO, and we will move to the third part of the examination of the content of consciousness, the NGP. And we will start with neglect. We will start talking about neglect by asking a question. Right hemiparesis is more frequently than left hemiparesis in patients with heavy body neglect. A true, B false. Neglect can be defined as a lack of attention to events and actions in the personal and extrapersonal space. Hence, it can be considered a spatial planning disorder. Our awareness of a space around us for all sensory modality is represented in the posterior parietal region of the lateral surfaces of each hemisphere. I have in this frame made the posterior parietal region involved with self-space orientation of the left hemisphere yellow and the one in the right hemisphere aqua. In this figure of a man looking forward with the brain exposed, I have marked the left side yellow and the right side aqua. Now I have added the yellow area in the left posterior parietal region. This area is in charge of surveying the right side of the personal and extrapersonal space, as you can see in this frame. That is the right spatial perception field. When it comes to the spatial perception field perceived by the right posterior parietal region, the spatial perception field, as you can see, is bilateral. Hence, the composite of the spatial perceptional fields, as you can see in this frame, is surveyed differently. The right spatial perceptional field is surveyed by the left and the right posterior parietal regions, whereas the left spatial perceptional field is surveyed only by the right posterior parietal region. So a patient with a left posterior parietal region lesion will lose the right spatial perceptual field recognized by the left posterior parietal region, but it will not have a great impact in the overall span of the perceptual field because The right posterior parietal region sees both. But if the lesion expands anteriorly enough to involve the primary cortex, the patient will present with a right hemiparesis. On the other hand, a patient with a right posterior parietal lesion will lose the left spatial hemifield perception, hence contralateral neglect will be present. And if the lesion expands anteriorly, a left hemiparesis will occur. So the answer to this question is B. Now I want to tell you about ARTEST and neglect. I will cite two cases. The first case is that of Anton Raderschild. This is one of the paintings which you may recognize from him. At 75 years of age, he had a right hemisphere stroke. After the stroke, he made several self-portraits. The time after the stroke, the portraits were done are included in this figure. Notice the evolution. Notice that at 2 months after the stroke, the left half of the painting is more incomplete than the right side. Then at 6 months and by 9 months, it is minimal. That is, the difference between the two sides is minimal. The second artist I want to tell you about is Federico Fellini. He was a movie director, but also a painter and a cartoonist. These views are from the CT scan taken 1 week after the stroke. You can see the right parietal stroke in both views. These are two drawings I have added to this frame that were made at about the same time. Notice that the left side of the woman face is missing, and also from the man. And when he was asked to bisect a line, he did so towards the right, as you can see. And I am indicating in this frame. How do we test for neglect? Viewing drawings made by patients, checking for bruises always on the same side, checking for dressing apraxia, which occurs with right posterior parietal strokes. The term apraxia is inappropriate for this condition since it is not consistent with the currently accepted pathophysiological explanation of apraxia. It would be better to call the findings here shown dressing neglect. But the term dressing apraxia is so ingrained in the literature that it's still called this way, and it is unlikely to change. Neglect is also evaluated by instructing the patient to do one of three things. Bisect a line. A normal person will bisect a line in the middle. A patient with severe left hemi-neglect will place the line to the right instead than in the middle. The second way is to draw a simple sketch. The normal person will draw what they see. The drawing of an affected patient with neglect will have parts missing on the left side. And the third way to check for neglect is to ask the patient to draw complex geometrical figure, such as the Ray Osterrieth complex figure. The one introduced now is from a patient with left hemifield neglect. A patient with neglect will miss most of the structures in the left side, as you can see in this frame. While considering neglect, I usually investigate for the possibility of constructional apraxia. This frame shows the figure I have just shown you when I was talking about neglect. Notice that the right side also shows significant errors in construction. Construction apraxia, which, as in the case of tracing apraxia, the word apraxia is misused, but it is here to stay, is defined as an inability to draw or construct 2 or 3-dimensional figures or shapes in the presence of normal strength, sensation, and comprehension. The primary deficit in constructional apraxia appears to involve the ability to perceive and imagine forms more than a deficit in the ability to perform the motor activities required to do so. The anatomical area most likely being evaluated when testing for the possibility of constructional apraxia is the posterior parietal region of the lateral surface of the right hemisphere, as it is for neglect. After neglect, we will talk about nausea. Here, I will start with some definitions. Nausea means knowledge, as in diagnosis and prognosis, words that we understand well. Topognosia means know where you are being touched. Stereognosia, knowing the shape of a 3-dimensional object when the object is being touched. Graphognosia, knowing the number or letter being written on your skin. Nosognosia, knowing you are sick when you are. And somatognosia, recognizing the parts of your body. Agnosia means not knowing. Atopognosia, not knowing where you are being touched. Agraphognosia, not knowing the number or letter being written on your skin. Anosognosia, not knowing you are sick when you are. Asterognosis, not knowing the shape of an object being touched by you. Prosopagnosia, inability to recognize familiar faces, including your own. Anosognosia, not being aware of having a disease. Asomatognosia, not recognizing part of your bodies. Now I would like for you to consider the following question. A patient capable of identifying the seat and the pedals in a bicycle but not the bicycle has A. Prosopagnosia, B. Anosognosia, C. Anosodiaphoria, D. Simultaneous agnosis. In this question, we have 4 possible answers. I will go through each of these possibilities and then we will choose the right one together at the end. The first possibility is prosopagnosia, which, as we define, refers to the inability to recognize a familiar person in picture or in flesh. Patients with this condition can describe appearance of a person. If we show the patient with prosopagnosia this picture shown in this frame and ask who it is, the patient may say mother. The answer is obviously incorrect. Then when we ask to describe what the patient sees, the patient appropriately recognizes the individual features and can describe them and make sound conclusions, even to the point of changing their original answer, like in this case to father. Then you put the picture away and ask, who was the first president of the United States? The patient will answer correctly. What is the anatomical area tested by asking the patient to recognize a face? If all other sensory modalities work well and semantic memory is normal. The area being evaluated is the bilateral fusiform gyra, also known as the temporo-occipital gyra, here shown in this frame. The second possible answer is anosognosia, a term that we have just defined. It means not being able to recognize an illness. As you can see in this frame, a patient with hemiparesis is asked, "How are you?" and his response is "fine." If you insist, he continues to say that he's fine, and even wonders why you are thinking that he's not. And if you direct him to the abnormal arm, he still thinks it is fine or denies it is his. The anatomical area most often involved in patients with anosognosia is the right posterior parietal area. The third possible answer in the question is anosodiaphoria. In patients so affected, when you ask, "How are you doing?" the patient will tell you, "I'm okay." If you ask about a specific action you see the patient is having trouble with, he or she will say that it is okay and minimize or brush aside the limitation. But the patient will recognize that there is a deficit. If you ask, "Can you use your left hand?" the answer will be no. Anosodiaphoria has occurred in patients with right hemisphere lesions at multiple sites. Lesions producing anosodiaphoria has been reported mainly in the right parietal region, but also in the temporal lobe. The fourth answer is simultagnosia is a condition where the affected individual sees specific details of a complex scene but fails to grasp the overall meaning of the image. Simultagnosia usually occurs with bilateral lesions in the occipitoparietal regions, such as bilateral infarcts in the posterior watershed areas. So the answer to this question is D. Now let's ask ourselves, how do we test for agnosia? First, by observing behavior, by targeted questions guided by history and physical exam, by identification of famous character, and identification of the right and left index and thumb. So we have spoken about gnosias and agnosias, and we are now going to talk about praxia, which is the ability of performing previously learned motor activity. Praxia, as we just defined it, would include walking and talking, since both are learned motor activities. Yet, most neurologists I know define praxia as a disorder of learned skill upper limb movements and tool use, in the absence of elementary motor or sensory deficit and general cognitive impairment, such as inattention to commands, object recognition deficit, or poor oral comprehension. Yet, among the neurologists using this definition, what is a learned skill movement and what is a tool is capriciously decided. This definition excludes non-limb apraxia as well as lower extremity deficits. For the purpose of this discussion, based on the book I am showing you in this frame, we will consider three types of apraxia. Ideomotor apraxia, which will be divided in three subtypes: parietal, sympathetic, and callosal. The second type of apraxia is kinetic, and the third type, ideational. As for aphasia and memory, I would have liked to present to you a model that would allow us to see the big picture, but I have not been able to find such a model for apraxia. I have found it possible to incorporate ideomotor apraxia and kinetic apraxia in one model, which I will use to explain these two conditions. The ideomotor and kinetic apraxia model can be designed using these images: the lateral surface of the hemisphere and the mesial surface of the right hemisphere. The arrow I have introduced originates in the Wernicke's area. The second arrow originates from the visual unimodal association cortex. And the third arrow originates from the unimodal somatosensory cortex. The arrows point to an area in the lateral surface of the left hemisphere in the inferior posterior region of the parietal lobe, corresponding primarily to the angular and supramarginal gyra, indicated here. This is the area of skill movements. Notice that as for language, the left hemisphere is dominant. So let's say that a person has to learn how to use a toothbrush. If you tell them to mimic using a toothbrush, the information would reach the skill movement area by route indicated by the arrow, that is from the Wernicke's area. If you showed them a photograph of a hammer or mimic the action of a hammer and ask the patient what to do with the object presented, the information would reach the skill movement area by the route indicated by the magenta arrow. If you give a person a hammer to hold, with the person's eyes being closed, and ask the patient what to do with the object in their hand, the information would reach the skill area by the route indicated by the magenta arrow. So the skill movement area, depending on the way we show the patient the object, voice, visual, or touch, will receive information regarding the nature of the object. From the skill movement area through the arcuate fascicle, the signal will reach the premotor and supplementary motor areas. From these areas, the activity travels to the primary motor cortex and by way of the genicle of the corpus callosum to the right hemisphere to make contact with the premotor and supplementary motor area cortices of the right hemisphere, but also to the primary motor cortex of the right hemisphere. The right hemisphere primary motor cortex also receives signal from the ipsilateral premotor and supplementary motor area cortices. So, in the case of ideomotor apraxia, as we will define it, there will be inability to perform a skill motor act despite the patient wanting to do it and no detectable motor or sensory deficit to prevent it. This inability will occur regardless of the model the request is presented, sensory, visual, or auditory. In the case of ideomotor apraxia of the parietal subtype, the apraxia will be bilateral and Wernicke's aphasia may be present, but there will be no weakness. The lesion in these cases is in the lateral surface of the dominant hemisphere in the parietal region, or in the arcuate fascicle. When the lesion is in the arcuate fascicle, conduction aphasia is more common than Wernicke's aphasia. Ideomotor sympathetic apraxia implies apraxia of the left arm occurring in conjunction to right arm weakness. The presence of right arm weakness by definition excludes the use of the term apraxia for the right arm. The term sympathetic is used to imply that the left arm, despite no weakness in sympathy or solidarity to the weak right arm, does not work. This type of ideomotor apraxia is often accompanied by Broca's aphasia. The lesion involves the premotor cortex, supplementary motor area, and the primary motor cortex in these patients. The last type of ideomotor apraxia is called callosal ideomotor apraxia. Here, the apraxia involves only the left arm. The lesion is in the genu of the corpus callosum, preventing the information regarding the skill act to be transferred from the left dominant hemisphere to the right. So we have explained ideomotor apraxia, and we will now move to explain kinetic apraxia. Kinetic apraxia, as we have defined it, implies an inability restricted to performing skilled movements not requiring real or imagined tools. The inability involves movements defined as non-representational, such as touching your nose or wiggling your fingers, and representational movements such as waving goodbye or sticking the thumb to make a hitchhike sign. Kinetic apraxia is explained by some authors as being due to small lesions in the left primary motor area compromising small fine movements but producing no weakness, or the right primary motor area compromising small fine movements but producing no weakness, the same as in the left hemisphere. Another explanation is a lesion restricted to the segment of the left supplementary motor area with connections to the left primary motor cortex, or a similar lesions in the right supplementary motor cortex. So we have talked about ideomotor apraxia, and we just have finished talking about kinetic apraxia. And now we will talk about ideational apraxia. Ideational apraxia implies the loss of ability to order a series of acts to achieve a goal. The classic example is the patient that has always made perfect sandwiches using these ingredients that you see in this frame, and all of a sudden he prepares a sandwich in this fashion with the bread inside the tomatoes. This type of apraxia is usually seen with diffuse brain disease such as dementia. Before leaving the subject of apraxia, it is important to state that the classification of apraxia and the definitions used in this talk is not shared by many authors, but I have found them more useful than any other classification. How do we test for apraxia? Each hand must be tested for each action. First, check for intransitive movements, that is, simple movements with no tools that normally do not have a specific meaning. That is for non-representational movements. Next, check for intransitive movements with meaning, that is for representational movements. Then ask the patient to mimic a representational intransitive movement. Then check the ability to do transitive movements by asking the patient to pantomime using a comb, pantomime using a comb by showing the comb and not telling them that it's a comb, and pantomime using a comb by giving the comb when the patient has the eye closed and let him feel what it is and then using it. The last thing we do when checking apraxia is to place in front of a patient an envelope, a stamp, a written note, and ask what the patient would do with it. This is only tested if there is suspicion of the possibility of ideational apraxia. Please watch this video from YouTube that shows a nice case of ideomotor apraxia. Before finishing this talk about mental status examination, I want to tell you about 3 syndromes because they are frequently found in your exams. The first syndrome is Kluver-Bucy syndrome. This syndrome is characterized by docility, hypermetamorphosis, which means a tendency to react to every visual stimulus, oral exploratory behavior, lack of fear, and in male animals and human hypersexuality, often misdirected, as you can see in this frame. The lesion in Kluver-Bucy syndrome is in both amygdala, or also involving the amygdalas and the anterior temporal lobes. Any condition affecting the mentioned areas can produce Kluver-Bucy syndrome, but the most frequent condition producing it is herpetic encephalitis. The second syndrome I want to tell you about is Wernicke-Korsakoff syndrome, which in reality implies 2 different syndromes, one acute and reversible, Wernicke syndrome. This syndrome is characterized by nystagmus that gets worse in the direction of the gaze, lateral gaze palsy, ataxia, and confusion. The added term of Korsakoff implies chronicity and irreversibility. The clinical manifestations of Korsakoff syndromes are memory loss, confabulation, and psychosis. The anatomical lesion in patients with Wernicke-Korsakoff syndrome is scattered. The site with the most prominent abnormalities are the mammillary bodies. You can see in this coronal MRI the abnormal signal changes in the mammillary bodies, but also in the transverse view you can see pathology in the mediodorsal nucleus of the thalamus, and in the sagittal view you can see pathology at the periaqueductal region and in the pons. Wernicke-Korsakoff syndrome is usually due to vitamin B1 deficiency. Vitamin B1 deficiency is often seen in patients with alcoholism. You may see it in the ER presenting in front of your eyes if you forget, as I did when I was a resident, to give B1 to chronic alcoholic patients before you start an IV with glucose. The third syndrome I want to mention to you is Gerstmann syndrome. Patients with Gerstmann syndrome, if asked to add, will not be able to do it, or they will do it wrong. That is, they have acalculia. If they are asked to write their name, the patient would make some dots or some lines in the paper, but will not write the name or any other statement that you may ask them to write. That is called agraphia. If asked to point to the right arm, they will point to the left as often as they will point to the right. And if asked to show you their index finger, often they point to the thumb or to any other finger. Remember that there is 1 in 5 probability of being right, so ask the question more than once. This video from YouTube is very good, and you can see there the exam of a person with Gerstmann syndrome. The anatomical lesion in Gerstmann syndrome has been classically located to the dominant angular gyrus. The conditions often producing Gerstmann syndrome are strokes and tumors. This is a transverse MRI of a patient with Gerstmann syndrome. It shows a tumor in the left parietal region. In this coronal view, you can confirm that it involves the angular gyrus. Thank you very much for your attention.